Welcome to the BMJ podcast. I'm Cameron Abbasi, Editor-in-Chief of the BMJ. Now, reports from the US about the potential for an H5N1 outbreak are causing headlines, and we'll find out how worried we should be about bird flu.
What we've known for 25 years is that there is a risk of these particular viruses, but in the last 3 or 4 years in particular, where we have seen massive infections in bird populations around the world spilling over into mammal populations and evidence of transmission among mammals, that suggests that the virus is getting closer to humans. So the risk appears to be rising as well. And that risk appears to have gone up markedly in the last 3 or 4 years or so.
As the UK political parties start releasing their manifestos, our NHS Commission has released theirs.
The concept of the NHS is very, very dear to people, but their daily experience of the NHS is getting worse and worse. And they've now in lots of places, lost confidence, and they're not absolutely sure that when they need it, it will be there for them.
And finally, the World Doctors Orchestra. First, though, to H5N1, our editorial on the potential for this outbreak to cause harm has become our best read editorial this week. So perhaps you share some of those worries. We have invited the two authors of that article onto the podcast, and we're going to delve in a little bit deeper. I have with me Wendy Barclay. Wendy is the Action Medical Research Chair of Virology and Head of the Department of Infectious Diseases at Imperial College London, and Christopher Dye. Chris is Professor of Epidemiology at Oxford University. Now, welcome both of you.
Hello.
Glad to be here.
Your article poses the question, should we worry about a growing threat from bird flu? Because, as you say, the hazard and risk of a major outbreak of H5N1 are large, plausible, and imminent. Well, we look forward to hearing why you say that. But first of all, Wendy, I wonder if you might tell us a little bit more about H5N1.
Sure. So we have this situation where a wild bird flu virus called H5N1 has found its way into several different mammalian species that have been sort of reported in the last year or so. And the one that's the latest is this report of outbreaks in dairy cattle in the United States. And there's two reasons to worry about that, really. One is that these viruses therefore have a bigger interface with humans, because we don't come into regular and lots of contact with wild birds, but we do come into lots of contact with animals we farm, like cows. And so there's a much bigger chance that viruses will hop from the domesticated farmed animals into humans than there are when they stick in the wild. But the other thing is that the viruses that are in birds aren't ready yet to cause an outbreak or a pandemic in humans. They undergo mutations to adapt for airborne transmission and replication in humans. And again, those intermediate species can be the mixing vessels or the adaptive pots where all of that happens. So this situation where we've got a very nasty bird flu virus crossing into animals with which we have a lot of contact, and in which the virus can mutate and become better adapted potentially for humans, is a really worrying situation.
OK, Wendy, thank you. I mean, Chris, how worried should we really be? I mean, that statement from your editorial is a pretty alarming one.
Yes, the words that you recited at the beginning of this piece, Cameron, that we think the threat is large, plausible, and imminent. Each of those three words has its own particular meaning, and it's important. We know from the available evidence, WHO has collected data over many, many years, that these so-called highly pathogenic influenzas, avian influenzas, have a case fatality of about 50%. So that's the potential hazard we're dealing with. That's the first thing. The second, about plausibility, is a question of risk. Wendy has already commented on this. What we've known for 25 years is that there is a risk of these particular viruses. But in the last 3 or 4 years, in particular, where we have seen massive infections in bird populations around the world spilling over into mammal populations and evidence of transmission among mammals, that suggests that the virus is getting closer to humans. So the risk appears to be rising as well. And that risk appears to have gone up markedly in the last 3 or 4 years or so. And then the third factor is imminent. We are, in general, worried about things that are likely to happen now or very soon, and rather less worried about things that are going to happen in the distant future. Now, we don't know whether the next big influenza event is going to happen tomorrow or next week or next month. But the fact, as Wendy said, that we're surrounded by very large amounts of virus at the moment in bird populations, mammal populations, domestic mammal populations, which are in close association with humans, leads us to be concerned about that question of imminence. So on all of those three parts, those three aspects of threat, large, plausible, and imminent, we think that there's a case to be worried at the moment.
The response from CDC and I think probably WHO, it's not at the same level as you're pitching your editorial. Why do you think that is? I mean, clearly they don't want to cause unnecessary alarm, but equally we do need to be realistic about it so that people take this issue seriously. Why aren't they being more proactive about this, in public at least?
Well, there's in general, I wouldn't point the finger at anybody for what they're saying. I would just make the general observation, Cameron, that you have a choice, really, when presenting the facts to the public. You could say, what does this look like right now? And that's the pitch that CDC are making and possibly WHO are making as well. So this is what's happening. At the moment, it's a relatively low threat. But if the consequence of that is no action by politicians, by the public, by no interest from media and so on, then we put ourselves in a position of vulnerability.
I quite agree with Chris. We're not trying to point the finger at anybody, and people will have different ways of managing this and dealing with it. I mean, I think whenever one is looking at these things, it may never happen. And that is the difficult thing about this type of science communication. We lived through in the early 2000s the threat of H5N1 bird flu as all of these human cases were happening and being reported, and that pandemic didn't happen then. And then we had an H5N1 avian influenza in 2013 in China, and that didn't end up as a pandemic, but we came close. And I think it's very difficult to manage and get the level of concern versus crying wolf correct in this form of communication. One tries to be balanced and reasonable, but in my opinion, and this is simply my opinion, but I've put it forward in the article with Chris, we are in as close a place now as we have been for a very long time for this H5 virus to be able to cross. And I totally agree, there's all sorts of others that may come from left wing that are really hard to predict, but at least we can look at the ones that we know about that are out there and say, look, even these ones are here, and we just simply can't ignore this.
So you're talking about pandemic preparedness, which, I mean, by most accounts, unless you're the government, we got horribly wrong last time around. What chance is there that anyone's going to do better, given that there are elections in the UK and the US, and actually half the world is in the middle of elections at the moment, and also the pandemic treaty negotiations aren't going too well either.
Yeah. Well, let me answer this or offer an answer. I'm sure Wendy has a view too, somewhat obliquely, which would be to say it's all very well for public health specialists and medics to say this is what we should do. But an important lesson from COVID that you referred to and from negotiations around the pandemic accord at the moment is that we have to understand why people don't want to do what we're suggesting. Otherwise, we're simply preaching to the choir. We know what the public health, we know that everybody in public health will agree with us, basically, but we've got to understand where the resistance is. We have to understand, and this is a case-by-case basis, we have to understand resistance, for example, to testing among cattle herds in the United States. And you can well understand why dairy farmers in the US don't want to expose the fact that their herds might be highly infected with a potentially dangerous virus. There are reasons. So what we need is a more cooperative approach to developing these arrangements, not public health by edict, because that will not work.
But what I'm worried about, Chris and Wendy, is that, as I said, we're in the middle of this political, electioneering. How is it possible for public health people? I mean, say you're Chris Whitty, who's the Chief Medical Officer of England. How do you get people to take this seriously? I mean, here's an editorial. Look at this by Christopher Dye and Wendy Barclay. You should be taking this seriously. But Rishi Sunak is busy campaigning. The same in the US.
Yeah.
I mean, I totally agree. And I'm a scientist. My view is that science can carry on regardless of the politics, provided there is adequate funding and communication and encouragement of people to talk about this. And I think, one of the purposes of an article like the one that Chris and I have written is really simply to get people talking, to get people thinking, to sort of prod and say, what does everybody else think about this? What are you doing? People who are working in diagnostic services, in the vaccine industry. I think if nothing else, we just need to raise awareness and say, just because we've had a COVID pandemic a couple of years ago does not mean to say that we're not going to have another pandemic. And I think that this, unfortunately, is a message that we have to keep telling the public and the politicians. Unfortunately, these things are not going to go away. The world is overpopulated and full of all kinds of interfaces between humans and viruses that come to us from different routes. And we need to keep on our toes. We need to be looking at the latest technology, the latest infrastructures and possibilities, and working out how we can do it better than last time.
We're going to have an event of public health importance regularly. We don't know what it is. But by building, for example, a public health laboratory service, just part of the system, what we're doing is we're building ourselves an insurance policy. And not just nationally, but internationally as well, because we are bound to have public health events of this kind. So what we need is a system that will deal with any kind of public health event. And that's not technically difficult to do. That's perfectly feasible. Let's do that. We're talking about flu at the moment, but let's use this discussion about flu to get people to think more broadly, including those who are responsible, politicians and others, for investing in public health surveillance systems, to think about the general problem of public health emergencies and how we address that.
If I could add, I mean, I think one of the things that we have learned and we should build upon is that generic responses, not only for public health and diagnostics, but for vaccines and treatments, are the way to go here, because we can't necessarily predict the exact pathogen. And in the 20th century, much of our sort of vaccine technology, for example, was quite specific. It was quite pathogen specific. But we are now in a technological era where that's not the case. We can develop platforms, even for antivirals, for vaccines, which can be then applied as soon as we know the sequence of the new pathogen. We can then apply those to sort of have a faster response. And diagnostics also with PCR testing, etc., is quite generic. But I think what we're really saying is, in peacetime and into pandemic periods, all of those things need rehearsing. They all need testing. They all need, making sure that this generic platform is right for different pathogens who are different in biological nature, like mpox versus flu versus another coronavirus. And that's, I think, what we should be doing right now is to check that the generic systems that we can put in place, because those are the sensible types of systems to be developing now, are going to be as good as we hope they will be for each of the different classes, at least, of pathogen which may cause another outbreak.
Thank you both very much. As we said earlier, that editorial by Wendy and Chris, Should We Worry About a Growing Threat from Bird Flu, is now available on bmj.com, links from the podcast page. As we said in our last episode, this is the year of elections, including in the UK. Our Commission on the Future of the NHS has set out the ways in which the NHS could make sure it is true to its founding principles and yet becomes more resilient in the future. Our commissioners have released their own manifesto, as it happens. Helen Salisbury, GP and columnist for the BMJ, joins Juliet Dobson, our opinion editor, to discuss.
We know from NHS satisfaction surveys that patient satisfaction in the NHS is falling, but we also know that it's a really kind of key issue for voters in the election and something that the majority of the population hold very dear to their hearts and something that people really value as a key kind of election point. But equally, satisfaction in the NHS is currently at the lowest ever level. Only 24% of respondents were satisfied with the NHS in the most recent survey. So how would you seek to rebuild that trust and confidence in the NHS?
Yes, I mean, it's very difficult. I think most Brits are really proud of the concept of the NHS. There's something so civilized about it. We all look after each other. You don't have to get your checkbook out when you're ill. The concept of the NHS is very, very dear to people, but their daily experience of the NHS is getting worse and worse. And they've now in lots of places lost confidence, and they're not absolutely sure that when they need it, it will be there for them. But there's another element to that restoring trust in the NHS is, I think, doctors are not convinced that the best interests of them and the patients are there in government agendas up to now. So we need to restore that trust in government, in NHS England, in the Royal Colleges, in the GMC, in all these bodies that have authority over doctors. We kind of need to be convinced that they have our best interests at heart, our patients' best interests at heart. It's going to be quite a tough road to get back there to where we once were, but it definitely needs doing. And without trust, it's very difficult to improve anything.
Yes, and as you've said, staff are key to the NHS and to restoring that trust and improving patient care. And we've heard a lot about workforce and the particular challenges around recruitment and retention. So what do you think are the most important things that need to be tackled in terms of recruitment, retention and staff well-being?
I mean, there's some very basic things like pay, but it's not just about pay. It's also about respect. It's about how people are treated. One of the ways we're not valuing people is not helping them have good careers. The people are finishing at the end of being a medical student and finding they've no idea where they're going to be working in 2 months' time because it's not been sorted out, and they're getting through those next 2 years, the foundation years, and not managing to get on any training programs. So there has been a plan to increase the number of medical students and doctors, but we also need a plan to train them further and get them to where they want to be eventually as GPs or as specialists. There's a real lack of planning, despite the fact we have a workforce plan. And there's also lots of issues about how we integrate other people who aren't doctors into the workforce, which we are a long way from getting that right.
Yes, and it's interesting. You've touched on so many different things there, but you've spoken before on this podcast, and you've written in your weekly column about this strange contradiction between patients not being able to get appointments with their GPs, but also that we're now seeing some GPs unemployed or unable to find jobs. I suppose funding is relevant to all of this, and I imagine, and it's also relevant to a subject that I imagine is close to your heart, which is general practice. And the manifesto calls for investment into general practice and to reverse the replacement of doctors with less highly trained professionals. So why is that such an important manifesto pledge?
Well, we definitely need more funding in the NHS. There's a calculation that there's about a £32 billion shortfall. If we'd been kept on the trajectory we should have been on, we would be a lot better than we are now. A lot of the time, health spending has just flatlined or even not kept up with inflation. And this is very much the case in general practice. And in the whole of medicine, money spent upstream is most effective. So most effective in public health, next most effective probably in primary care, in general practice. Actually, by the time you are in the hospitals, things get very expensive. Yeah. So if we want to keep people well, one of the places we should be spending is in general practice. We should be enabling every patient to have a named GP and continuity with that GP. There's loads of research that shows that actually continuity of care is the thing that keeps people well, keeps them alive, keeps them out of hospital, stops them having emergency admissions. That's the thing that most works, and we should be spending the money in an evidence-based way, and that would be one thing to do, is to rebuild general practice.
Yes, and as you say, we know that better access to GPs and continuity of care improves patient outcomes and is cost effective and very important for prevention, which is another key point in the manifesto around prevention. And we know that the health of the UK population is deteriorating and inequality is widening. So how should some of those causes of ill health, such as, for example, tobacco or alcohol, junk food and gambling, be tackled?
Yes, I always find this quite frustrating, and our commissioners have really focused on this as well. The actually, so many of the things that we could do to improve public health are not really that complicated. If you look at the example of tobacco, actually we've had really successful reductions in tobacco consumption over the years, through tax, through legislation, through restrictions of where you can smoke. It's coming down. It needs to come down further, but it has come down. And if you looked at those things and thought again, okay, well, what levers have we got to decrease alcohol consumption, for example, or improve diet? There's lots of things to do with tax and regulation that you could do to improve public health. It's very interesting that that's not been done and not been promised. And I think gambling is, there was this massive deregulation of gambling. It's a huge harm. That was clearly a stupid thing to do in the first place. That needs to be reversed, because gambling overwhelmingly harms poor people. Yeah, it's a real driver of inequality. If they aren't poor when they start, they're definitely poor when they finish.
Yes. And inequalities and poverty are also driving another sort of very fundamental issue, which is around child health and poverty, which again, we know that's something that has got substantially worse. A recent UNICEF report placed the UK at the bottom in terms of child poverty rates. And in recent years, between 2014 and 2017, in England, we saw a rise in infant mortality. So what do you think needs to happen first to really recognise the huge scale of that problem and to prompt action?
It is a scandal that so many children are growing up in poverty and insecurity, and that's insecurity in housing, and it's food insecurity. And we know that the changes in benefits that have come in over the last few years have disproportionately affected women. and affected, particularly women as single parents. And if children grow up with food insecurity, with housing insecurity, they are so much less likely to fulfill their potential. And it's such a waste. It's such a waste of lives and such a cause of misery. So we need to look very closely at our welfare system and make sure that the benefits that we have really do allow families and single people to live a decent life. And that will pay back in terms of improving their health. But also, even if it didn't, it's the civilized thing to do, isn't it?
Yes, yeah, you're right. It is shocking that we put up with it. And, children's health is everyone's health. It's our future health, and we certainly need to do something about it. So finally, Helen, if there was one thing that you could implement now, and it can be something big or something actually quite small, what would it be?
I think we should all be focusing on planetary health, actually, because whatever else we do, the thing that is going to have the biggest impact, probably in my life, certainly in my children's life, is the climate emergency. And it's going to dwarf everything else. The NHS is said to produce maybe 4 to 5% of the greenhouse gases in the UK. We need to really think about how do we reduce our carbon footprints? How do we make sure that all fossil fuels stay in the ground and we find other ways of powering our lifestyles? Because otherwise, anything else we do is going to go up in flames.
Thank you, Helen. Wise words. And yes, thank you so much for running us through that manifesto. I think we can but hope that the next government will read it and take some of this on board.
That was Helen Salisbury, GP and columnist for the BMJ, talking to Juliet Dobson, the BMJ's opinion editor, about the Commission on the Future of the NHS and its manifesto. All of this is now available on bmj.com, links in the podcast notes. It can be hard to tell what you should be paying attention to in this election and in every election, so our daily email alert curates the most important health-related news for you. Sign up at bmj.com/today. Finally, the World Doctors Orchestra, which was founded in 2008, has grown from 60 participants from 12 countries to more than 1,800 doctors from 60 countries. And one of those doctors tells us more about it.
Yeah, my name is André Couto Dias. I'm a junior doctor here in Portugal. So the World Doctors Orchestra is an orchestra where people from all over the world take part. You don't need to be necessarily a doctor, but most of its members are. We rehearse for 3 days very intensely, and then we do a concert on the weekend, maybe 1 or 2. In medical orchestras, we are amateurs, and in that sense, we get to live an alternative life, so to speak, as a full-fledged musician for a couple of days. And that means that we tend to be very enthusiastic on stage. People have often remarked that we have this overwhelming energy and we seem so happy. And one would even argue that sometimes we enjoy it more than the actual professionals. it does feel quite intense. Sometimes I would say you get more tired physically than before you started your vacation, so to speak. But emotionally, it's very rewarding, I would say. And then everyone goes back and dwells on their post-concert blues.
That's it for this week. All of the articles we mentioned are now available for free on bmj.com, and we've put links in the podcast notes for you. We'll be back in a fortnight with another episode. Make sure you've subscribed, and we'll see you then. I'm Cameron Abbasi. Thanks for listening.